Kapıyı kapatabilir miyiz acaba? Okay, good morning, dear guests, distinguished participants. Welcome to the first session of the third day of the conference. And first of all, I would like to thank to the EMAT board and to the organization committee for their kind invitation. And also, it's an honor to be the moderator of this session. I started my emergency medicine residency in 1993, and also I met with Judith in 1995. It's also same age. And since then, the emergency medicine has been recognized as a primary specialty in lots of different new countries. And now we have a great talk about the opportunities and threats of emergency medicine in the last decades. And also we are here to listen our valuable speaker. I would like to invite dear Judith to the stage.
Good morning again. There we go. Well, thanks everybody for waking up so early. We'll talk about emergency medicine, our future. And while I'm here today to talk about the future, I can't but help because I knew all these guys when they were residents in Izmir, and I was also a very young faculty coming to Turkey. So it's great to see how emergency medicine has progressed and is so sophisticated now in Turkey. So I'll give an overview of our future. As a matter of fact, today, many of the talks that are scheduled are about the future and things that we should think about to incorporate in our practice in the upcoming years. My major thought about the future is emergency medicine really needs to drive the bus and become a leader in a lot of changes in our society that we want to do to improve the health of the public. And even if we are on the right track now, we have to keep moving forward, because if we just sit here, nothing will happen. If we just sit and enjoy the positive things we've done without moving forward simultaneously, we aren't doing the right job. A major part of our job is being able to communicate better who we are and what we are. That's always been a problem with emergency medicine. What is our message? Well, my message to the world is we're the only population-based specialty. And the definition is easy when we think about what we do. We treat all disorders, all ages. We have no target population like other specialties. We're classless, we're genderless. You have a symptom, a complaint, we treat that. If you have a social problem, we treat that. Any day, any time, any acuity, no specialty does that. We treat small things, and we treat big things. We provide care when other services fail, and our EDs reflect the disease and injury burden of our community. And we see that in every country and every region around the world. The ED tells you what's going on. Now, we know that because it's part of our practice, but we have to communicate that to others. Because we're population-based, we are natural health care leaders. We do disease and injury surveillance. We do a lot of prevention and intervention. And although we may complain about our electronic medical records, they provide us with large databases, which are a gift to our specialty. And we're partners of other groups that work taking care of the population. So we have to really communicate, how are we unique? how can we explain that to others? We can tell stories, and our stories need to say, we treat large volumes. We don't treat one patient at a time like an office setting. We treat large volumes simultaneously. The cardiologist does one cath at a time. The surgeon cuts out one appendix at a time. That's not true with us. So we treat many patients simultaneously. And we can pivot and switch around anytime we need to, from seeing a patient with back pain to managing a cardiac arrest. And another thing I've noticed even more and more as I practice and work as a patient advocate, work as a doctor trying to talk other specialists to help us out, other specialists often talk about what to do. We're the only ones. We just do it. So we need to understand these differences and communicate them to others, and that will increase our power as a specialty. So there's a lot of things to think about to shape the future. Some are tough. Others are going to be easier to accomplish. I was just talking to my friend Yildiray about ED overcrowding. Is it a problem in Turkey like it is everywhere else? Of course. In the US, we've been unable to fix this for 50 years. So my natural feeling is overcrowding has become an essential characteristic of a busy ED. And a lot of this happens because we see multiple patients simultaneously, and we move the patients along faster than the hospital can deal with them. So we're dealing with, in the ED, at warp speed. The hospital is going at turtle speed, very, very slow, and that's a big difference. In Turkey, there was actually a very recent publication in the Archives of Public Health comparing ED overcrowding now with an article that Dr. Cem Oktay published in, 2003, and the same volume of ED overcrowding has persisted from 2003 until now. So it just shows you this is a chronic problem. I certainly don't have the answers. We talked the first day about it being a societal or a country need to really help, because there are many factors that the ED cannot do. The other big problem that we're having difficulty with are mental health needs. And this is a double-barreled problem, because the mental health issues are stress on the emergency department and the EMS staff because of the large number of mental health patients that are crowding our EDs. A lot of times, the patients with mental health issues way outnumber the patients with medical needs, and they require so much monitoring, they take away our care from sick medical patients. We have made some changes on that in the US, and this has been the change in EDs to develop their own managed psychiatric area with the policies, procedures, the staff, the psychiatrists, and the social workers under the direct care of emergency medicine. And where we've seen some changes, that's where it's occurred, in those emergency departments that have been able to have a separate psychiatric ED area under ED management. It's really diminished ED wait times in many cases, not in others where multiple evaluations and inpatients that are needed, but it's made a difference. So sometimes we become overwhelmed with problems we can't solve. This is one that we solved a little bit. I think telemedicine is the biggest thing in the future. In the United States, jobs in telemedicine are skyrocketing. I heard last night that the Veterans Administration system in the US is now starting telemedicine. They're trying to incorporate it in the EDs, and they're trying to start it, I now know for a fact, in the emergency department in the Detroit, Michigan VA service. And they're trying to hire trained emergency physicians to really manage that. So we've got to think about that when we train our residents. There are a set of speech habits, behaviors, ways to manage patients over telemedicine. We have to make sure there is privacy and security when we're talking to patients who over telemedicine. I was a telemedicine physician working with the Department of Psychiatry for about 6 months in the middle of the COVID period. And it would be amazing. You'd have to think, where is this patient? There would be kids running around, family walking in and out. Patients never had computers. You were doing all this with a smartphone and using FaceTime. So you had to be very careful with privacy and security as you were discussing confidential questions with the patients. So we need to start teaching our residents now how to work in telemedicine. We've used telemedicine in hurricanes in North Carolina. Now in 2018, there was a very bad hurricane that devastated our eastern coast of North Carolina, and 800,000 people had to evacuate the coastal areas. And many of them were, if they had places to go, that's where they went. If they didn't have family, friends, money for a hotel, they were placed in shelters throughout the state. So several thousand were placed in shelters in central North Carolina. And that would be 4 hours away from their normal homes and their normal medication. Well, the EMS system set up a telemedicine operation. These people were not sick. They were in shelters. There was no medical care there, but they needed their medicine. Diabetics needed insulin. They needed Coumadin. They needed DOAX. They needed medication for minor things. So through telemedicine, hookups were set up with the local pharmacies who could then bring in the needed medication to the right patient in the shelter. That's the first reported use of that in that kind of a natural disaster. The doctors who were running that had already had a long experience with telemedicine, so they knew exactly what to do. Now, maybe you think talking about drones is crazy. I don't think it's crazy. You see this picture here? It is part of a study that was done, kind of funny, at the University of North Carolina. They've had a couple of publications from this. And what they did was sort of arrange a simulation of a cardiac arrest in the golf course. And they looked to see, well, how long did it take to find the AED? How long did it take to call for help? How long did it take for EMS to come with an AED to the golf course to resuscitate the patient? There was bystander CPR in part of the simulation. Well, it turned out the quickest way to get an AED there was with a drone. Now, I took a walk around the property here, went all the way to the coast, and I looked at the golf course, which is huge. I've looked around for AEDs. I sure don't see any. If a gentleman or a woman had a cardiac arrest on the golf course here, your best bet would be to have a drone flown in with an AED to really defibrillate. And you'll look on this slide, there are lots of examples already of drones being used. You can use them to deliver blood products. In a Turkish simulation, again, that was published this month, drones were better than snowmobiles to identify victims who were crushed in an ambulance. Now, who is going to operate those drones? It should be emergency physicians. It could be paramedics trained and managed by emergency medicine. But we should be the ones who are thinking about this in the future. I think as we think about growth, our own personal growth and growth within the specialty, Here I am again with telemedicine, because there are so many opportunities. We can do ED triage, we can do follow-up, and during the COVID epidemic in New York City, there were many publications on the ways, the excellent ways that emergency medicine did COVID follow-up on patients who were discharged from the ED. They had to do it. All the doctors closed their offices. The clinics were closed. Who else was there? Just emergency medicine. There's a great opportunity for clinical trials and research development. And we heard some presentations yesterday from Dr. Sooner about how at Brown University, during the COVID epidemic, they were able to do a lot of research projects looking at different methods of treatment right out of the emergency department. And there is an e-consent that was approved by the FDA in 2020 that can be used in the US. Other business and professional opportunities include web-based training systems and resources and testing programs. And there are a number of individuals in Argentina who developed these kinds of systems for training and teaching in Argentina. They're very successful. The individual who's developed them no longer has to work in the ED. He's doing so well. I think it's up to the ED of the future to develop and to use innovative tools. Now, there are some tools that have actually filtered down to the ED from other services. For example, very early on, it was obstetrics and gynecology that started us using ultrasound to detect fetal heart tones and fetal viability. So that filtered down to the ED. Cardiac work filtered down from cardiology to the ED. But we're at the point now, we don't need that kind of stuff filtering down to us. We need to start it, and we need to be the leaders, and we are. At this meeting, there are tons of discussions and simulations on advanced ultrasound techniques. We can be innovative in data analysis and use it for our safety and quality reporting. There are a lot of opportunities for use of REBOA, and it is, of course, a temporizing measure that requires a surgeon to take care of the patient, but a properly trained and retrained emergency physician can do REBOA. Now, we don't really know how successful it is. The cases on application of REBOA have been sort of mixed. What about ECMO? One of my very good friends who works in Texas, as an ER physician, because he was smart and really good, he was quickly asked to go to the ICU. It took a few days before they put him in charge of the ICU. And before you knew it, he was doing ECMO. Well, these are all techniques that may be important for the emergency department of the future. Things like thromboelastography, they don't necessarily have to stay in the operating room. They should be done in the ER. Infrared thermography, rapid response EEG, portable MRIs, these are all things that belong in the ER of the future. And you're going to hear a lot in the lectures that are coming up about AI, which really we should call augmented intelligence, not artificial intelligence. And there are a lot of examples of how it may be good and the mistakes that occur with the use of AI anyway. So that's a complicated area, but it's already hitting radiology, and it's certainly possible it's going to be a part of emergency medicine care. Now, we need to develop leaders and entrepreneurs in emergency medicine. And there's a real dearth, there's a lack of entrepreneurship in emergency medicine. There are classes and there are a few mentors that can develop entrepreneurs in emergency medicine. And we need to think about how to encourage that in our residents and faculty. And as you're in the audience, Maybe you can think of some emergency physician entrepreneurs. I can name you from the first generation, Jim Brosolo, who developed the Brosolo tape. Do you know that man only had an internship? He never even did a residency. He's a board-certified emergency physician under our practice track. So think of what Jim has accomplished. How many here use MD Calc? Probably everybody, right? Do you know who developed MD Calc? Does anybody here know? Ah, emergency medicine. Joe Habush and Graham Walker were residents in New York. And as residents, they got sick and tired of trying to find the right tools, decision tools, to apply to patients. So they started a personal collection. Out of that grew their business, MD Calc. And I will name a current generation emergency physician, Dr. Sulam Sener. If some of you heard what he has been doing, he is a true entrepreneur and an innovator. So we need people like that in emergency medicine. Now, one needs tools for leadership and innovation. And this is actually an interesting thing as medicine and medical schools have been open to people who are applying. We're seeing a fair number of individuals who had other jobs in law, in economics, in business, who switch and say, I can really help people, I want to be a doctor. So we're seeing individuals with those backgrounds, they already have an MBA, coming into medical school and becoming emergency physicians. And of course, you have the opposite, and that is faculty who are starting to get advanced degrees and advanced training while they are working in emergency medicine. In the past 5 years, 3 faculty at the University of North Carolina in our ED went to get their MBAs while they were working. 2 of them cut down to part-time so that they could study. But we have to give the opportunity for giving time for these advanced degrees. A young woman that I hired for a different research project was working in the ED. She was a nurse. While she was a nurse and a faculty member, she got her PhD in informatics. This young woman, again, while being in the ED, she's the one of a core of 3 people that developed the ECI, Emergency Severity Index. So these are all people who are trained and working, continuing to get the tools to make themselves successful as leaders and innovators. Again, in the future, we need to encourage versatility in care. And I think those of you in the audience can really think of different ways to be versatile. We heard a talk yesterday about hospital-at-home interventions. Many EDs are now integrating palliative care services with ED care. We're increasing our knowledge in our treatment of mental health and addiction services. The thing is that emergency medicine can do care anywhere. We can do care in the parking lot. We can do care in the waiting room. As a matter of fact, Canada has a lot of papers, many of them are kind of humorous, on the care that they can provide in the waiting room. So we need to think about how we can be versatile in our care. Most importantly, as we're working as emergency physicians, we need to be a champion of our specialty. We need to describe through stories how we make a difference. We're at the front line of everything. Be friends with the media. Make sure the media can help formulate our message and get it across to the public. We, of course, became very famous as healthcare heroes with COVID. But you know, people's memories, they go away. They're going to forget that now that COVID is sort of over. We have to continue to make sure that everybody knows our story and the difference that we make. So I guess the focus of this whole talk is there are so many opportunities for the future. You need to look around, see what your colleagues are doing, see what's available to get other tools to expand your practice, your innovation spirit, your entrepreneurship. You find your spark, and you'll light your fire, and we'll have a super future in emergency medicine. Thanks very much for listening.
Thank you very much, Dr. Tintinali. And any comments or questions from the audience? No? Okay. Okay, thank you very much. And we are going